me tell you a little bit about Ivan. He is actually both an attorney and a pharmacist. Thank you. And he is the founder of No RX Abuse, and that's the coalition in Shasta County. And he is going to tell us a lot about his work with multiple stakeholders there. So, welcome, Ivan.
Thank you, Kristen. Good afternoon. I hope you enjoyed your lunch. It was very tasty, and I'm hoping that you won't fall asleep during my presentation. I don't have any fancy slides or anything like that, so I won't bore you with that. But to kind of give you a brief overview of what we have done and how we started in Shasta County was, and I was still working in a pharmacy as a practicing pharmacist. I noticed that over the last decade or so, the prescribing patterns have shifted significantly upwards with respect to opioids and other controlled substances. And the whole community perception of how to use or misuse prescription drugs kind of have been moving towards the perception that it's perfectly fine to abuse prescription drugs or to use them inappropriately, whereas it may be frowned upon to go out and use heroin, etc. And we all caution our kids against that. Most people in our community at least perceived it as perfectly fine to go out and abuse Norco or Percocet, etc. So about 3 or 4 years ago, I started talking to various prescribers that came to my attention during my dispensing practice when I saw the pattern. And so I came to talk to a few of them, and some of them received me well, some of them slammed the door in my face. It happens. So we started this coalition to basically educate both prescribers and the patients. And I think that what is pretty important in this effort is to focus on the demand side, not necessarily on the supply side alone. Historically, whenever it came to regulating misuse or abuse of any particular substance, the efforts were primarily aimed on the supply side. Whether it was in 1930s, the prohibition, that we all know how well that one worked, or the fight against illegal drugs or abuse of prescription drugs. As long as we're going to be focusing solely on the supply side, we're not going to get anywhere. As long as the patient will perceive that it's perfectly fine and acceptable to misuse the product, there will always be somebody who will supply it. Whether it be a pharmacy or whether it be a legal dealer, there will always be somebody. So the focus of our coalition and our campaign is to not only work with the prescribers as the point of origin, but also work with the patients. And that's where we found that there's a big difference and kind of a dichotomy between what the patient hears from their respective healthcare providers. As a practicing pharmacist, I frequently counsel my patients on the use of opioids and on the inherent risks that are accompanying the use of opioids. And sometimes I get this blank stare on the patient's face, and I'm asking, okay, do you not understand what I'm telling you? And it's like, well, I understand that, but my doctor didn't tell me anything about that. My doctor told me it will help my pain. And now you're telling me how incredibly dangerous this thing is. What do you know? Did you go to medical school? I said, no, I did not, but your doctor probably should have talked to you about it. And that difference between those two messages, that creates a gap. Because, for Joe Sixpack, who comes to the doctor, says, okay, I hurt my back lifting a sack of cement, give me something to help me. Doctor says, oh, this will help you, writes him a prescription. Then he goes to the pharmacy, and pharmacist spends 10 minutes talking to him about how incredibly dangerous these drugs are. I was like, what does this guy know? My doctor said it would help me. He said to take 3 a day. Well, 3 is good, 4 is better. And off you go. Next thing you know, patient becomes dependent or addicted to this particular product. So part of the focus of our campaign or our coalition is to work with the prescribers to send one coherent message to the patient that these drugs are great to help them with their pain. And they will do that if used appropriately, but they're not without risk. And that's the message that we're trying to send to the prescribers. Sometimes we're successful, sometimes we're not. But it kind of worked. Another strategy that seemed to work, at least in our coalition, is to reach out to not only medical providers or not only healthcare professionals, but to the general public, and do it through various organizations. What was very successful was Rotary clubs. Rotary clubs are comprised of community leaders, people who are really concerned about the well-being of their community, and they're also people in a position to influence the mindset and influence the behavior of others. Those are the people that we want to target. If you can get to those people who can then spread the message, you save yourself a whole lot of work, because other people will do that work for you. We were not tremendously successful in getting into schools, unfortunately. We've tried, and that effort was kind of shut down on the account that, well, you guys are not educators. We know how to educate people, so we don't really need your input in that. I beg to differ, but that's just my personal opinion. So those are the two strategies that seem to kind of work for our coalition. Another one that I can't take credit for, but somebody else in our coalition had this great idea, and I think it's really awesome. We put advertisements or public service messages on bus shelters. It was relatively inexpensive, and it gets a lot of exposure, at least in our areas. So even though not necessarily a whole lot of people take the bus, but everybody who drives past that bus station will see that. It was a relatively inexpensive effort and an expensive way of getting across that message. So those are kind of the three strategies that really worked for us. Any questions or thoughts? Kelly.
So what did you find that worked well and didn't work well when you went to talk to a doctor?
Well, a lot of times the initial contact is probably the most challenging, given the fact that I am myself not a medical professional and I try to do the academic detailing. I get a cold shoulder saying, well, you're not a doctor, how are you telling me to practice medicine? I don't need a pharmacist or a lawyer to tell me how to practice medicine. What sometimes does work, though, is when I give him the perspective of, this is what can happen to your medical license if you don't listen to me. And that actually worked quite well in a few instances. And I have some real life examples from our county. So that sort of generates a good traction.
Are there other questions for Ivan? And we'll have more time at the end, too, yes, we have a question here. And do you mind, since we have some friends out there, if you could just mention your name and where you're from?
Okay. Sure, you can look at them if you want. Hi, I'm Debbie Van Olsten. I'm from San Mateo County. And I was wondering, when you talked about going to Rotary Club, what were maybe your key focus that you talked to them about to get that discussion started?
It really depends on the composition of the club, and I try to tailor my presentation to that. I usually reach out to either a member of that particular club, and then they introduce me to the leadership of that club, and then we gauge it based on the composition. If there's enough representation of healthcare providers, I increase the healthcare-related data into that. If it's primarily laypersons, then I tailor the presentation more towards the overview of the impact on community of the improper use of drugs. And I try to not to portray it as downright abuse. I usually work into the angle of inappropriate use or misuse of prescription drugs, because very rarely it actually starts with the intent to abuse these drugs. The vast majority of these cases are that the drugs are just being used inappropriately based on the lack of knowledge of the patient. And I spoke to a number of physician groups as well. And one group in particular was interesting. It was a group of emergency room doctors. And I asked them, just to get my better perspective, because I'm not in that practice, I asked them, what's the average time you can spend with the patient? And the answer was about 3 to 3.5 minutes per patient. And in those 3 minutes, how realistic is it of me or anybody else to expect that the doctor would actually go into any great depths to spend and discuss with the patient the risks associated with the prescribed medication? Completely unrealistic. So, that was kind of an eye-opener for me, because my expectation was, well, why can't you tell your patient what you're prescribing? Now I know why. He really can't. But that's where what also helps is to enlist pharmacists in your community. And it helped us tremendously, not because I'm a pharmacist, but I'm no longer practicing pharmacy, but we had members of our coalition who are currently practicing pharmacists. And they can point us into the direction of the practices, the prescribing practices that may need a little bit more attention in terms of the academic detailing and maybe some education, basically help us to target the efforts where it could generate the most effect. And that's why pharmacists are really of great importance in this particular effort, because they can also disseminate a lot of information, and we use local pharmacies to distribute the flyers that basically outline the risks associated with chronic use of opioids that are not limited to addiction. Pretty much everybody these days knows that chronic use of opioids can and does result in addiction, but there's a whole bunch of other side effects that are not as well known, yet they're very real. And if we can help, if we can enlist our pharmacies to distribute this information to the patients at the point of dispensing, because that's the ideal point. The pharmacists are required by law to provide meaningful consultation to every patient who receives a new prescription or changed prescription. Let's use this resource and help them to drive the point across that yes, these drugs are great, but they're great only if they're used appropriately.
Okay, we have a question back here. Let's take this one first. Okay.
I'm Cheryl Blankenship-Cooper's from Santa Clara County. I grew up in Shasta County, and I'm wondering how you might work with faith-based coalitions in faith-based.
Religious organizations? Yes, we've actually worked with a couple of them. I made presentations for a couple local churches. Actually, not in Shasta County. It didn't happen in Tehama County, but I still consider those two kind of one piece. And it works quite well. Again, because the people who attend these organizations or who are members of these organizations usually are in a position of influencing others and setting an example for their local community. And again, those would be the people you would want to target.
Okay, we have a question back here.
Yeah, hi, I'm Steve Wirtz for the California Department of Public Health. I'm interested in learning as much as I can from you about how you're approaching this demand side in terms of the messages. And I've heard you talking about the making sure people understand the risk. I'm wondering if you see some connection about two questions, I guess. One is about alternatives to pain medications that might work, if that's part of your message. And then two, is there anything you're doing around the sort of patient satisfaction survey aspect of things, that patients come in if their expectations are to get the drugs, and then do you see a connection? I know there was a recent article that says there's not as big a connection as possible, but do you understand the question about patient satisfaction surveys? If we change their expectations, then we might change the satisfaction surveys and put less pressure on doctors to prescribe to keep their satisfactions up.
Okay, thank you. So I answer your second question first, because the answer would be shorter. The answer is no. Unfortunately, at this point, we have not dedicated the time and resources to conduct any patient satisfaction surveys, but I think it's a very good point that you just made, and I'll make a mental note of it, and I'll introduce it to the members of my coalition. I think it's very important. The first question related to the patient's expectations, that the target of our effort at this point is primarily those patients who are not really patients yet. And it's to create to move away from this perception that we have as a community in this country that there's a pill for everything. Like there's an app for that, so there's a pill for that. And I can tell you from my personal practice, I started practicing pharmacies overseas probably 30 years ago, and it was really not common to receive a demand for prescription drugs in such a volume as we see it here in the United States. So it's a kind of a cultural thing that we're really expecting to receive some sort of medication for just about any treatment. And part of my presentations is the fake commercial for Pretendatrine. Many of you probably have seen it, where this young lady on the television says that, well, I didn't know I was sick until I went to the doctor, and he talked to me about this Pretendatrine drug. And I know that whatever's not wrong with me could be not wrong with my kids. But thankfully, there is pretendotrin for kids now. And, whatever's not wrong with me is being treated, and I'm very happy about that. And that's, partly due to the big push of the big pharmaceutical companies. Not that I want to knock them down, but if you turn on your television, you see 3 basic categories of products advertised very prominently: cars, drugs, and food. Not necessarily in that order, but those are the 3 most advertised items on our television. So it's just driven to our minds that there's got to be a pill for anything that ails us. So our target are the people who did not become patients yet. And the objective would be, and it's kind of the holy grail, I don't know if it's achievable, when I as a patient go to the doctor and the doctor tells me, I'm going to treat you with these highly powerful opioids for whatever disorder you have, that the patient would actually ask, are there any risks associated with these drugs? Or do I really need this? Are there any alternatives that I can use rather than this highly addictive drug? I don't really want this. I would like to use this as a last resort. I don't want this to be the first line of treatment. So yes, we do promote other treatment modalities, whether it's a physical therapy, acupuncture, etc. The significant downside of that is, and we've run into that within the context of third-party payers, these treatments are generally not covered by most private insurances. So then we have a patient who has to make a pretty big decision. Do I go out and spend hundreds, if not thousands of dollars on alternative therapies that I have to pay out of my pocket, or do I take the prescription, go to the pharmacy, put down $5, and call it a day? And unfortunately, the decision in many, many instances is decision B, because of the simple reality that the patient is not in a position of affording these expenditures associated with the alternative treatments. What was very beneficial, excuse me, is the fact that a Partnership Health, who was and still is, it's a driving force actually behind our coalition. I have to give Partnership Health a great credit for that. Without their help, we would really not be able to succeed at all. They are one of the very few plans that actually cover alternative treatment modalities. So they provide the patient the option, if their prescriber chooses to recommend or prescribe one of these alternative treatments, they pay for it. So the patient truly has a meaningful choice of going out and make the selection. Do I want to use the opioids as the first line of treatment or not? Unfortunately, many of the private insurances like Blue Cross Blue Shield, they just flat out say no.
So, hi, Dan Petticourt. I'm the Public Health Director at Contra Costa. So following up on your comments about talking to provider groups, given that we know more and more about the clinical efficacy of opioids after, at 14 days, they basically from 14 to 30 days, they're waning. And by 30 days, really questionable whether they have really any ongoing therapeutic effect. So are you weaving that message into what you deliver to particularly your clinical audiences? And also, my thought is helping patients understand that helps them ask better questions about alternative modalities.
Absolutely. The part of the decreased clinical efficacy of opioid treatment for chronic pain is part of all of our presentations. And we try to utilize medical personnel, obviously. Dr. Vovakis has been great help in that from Partnership Health. He's engaged in quite a bit of the academic detailing, so he can deliver the clinical message better probably than I can from my professional standpoint. I can talk from the pharmacist standpoint as well. But again, I no longer practice pharmacy, so having a physician deliver that message is a great idea too.
Okay, thank you so much, Ivan. And some of the key stakeholder groups I heard that you're really working a lot with include the pharmacies, physicians, the community through Rotary clubs and public education strategies like bus ads and health plans. So it's really helpful for us to hear about that. And then our next speaker is from Santa Cruz Coalition. Her name is Pam Connolly. She's the project lead for the coalition, the Safe RX Santa Cruz County Coalition. She works at the Health Improvement Partnership, which is the lead organization for the coalition. So thanks so much, Pam, for being here.
Thanks, Christine. Hi, everybody. So, as Christine mentioned, I'm Pam. I'm from Santa Cruz. For those of you who don't know, our county has about 265,000 people, so we're a pretty small county, and our coalition is pretty new. So we came together as a coalition as a result of the CHCF initiative, and our first steering committee meeting was in January, I think. I have a couple of steering committee people here, right? I think, raise your hands. Yay, there's a couple. So I'll talk a little bit about our process, our coalition building process, and how we engaged stakeholders, and then a little bit about how we took the work, we've been calling it a roadshow, took it to different stakeholders in the community to engage them in the work. So when we came together in January, we had a really good turnout for that first meeting, and I kind of took a chance. Our coalition right now is pretty healthcare focused. We're working mostly with healthcare providers and doing presentations to healthcare agencies. But I took a chance at that first meeting and did something a little touchy-feely, and probably more touchy-feely than most people who are at the meeting are used to anymore, or maybe they've forgotten. But I had us do a little bit of diving into what we want to see in our community and what our core values are that drive the work that we're doing. Why did we come to this meeting? And some really great stuff came out of that brainstorming, stuff about our values and how we want to see our community thrive and what that takes, and kind of distilling that down to create our vision statement. And I'll share with you that the values that came out of that were really safety, health, compassion, and equity. And so those are the things that we want to see in our community around this work, happening around this work. And so we've really used that to drive all of the work that we do. We keep that kind of as at our foundation of the work and bring ourselves back to that to make sure that we're holding true those things that we really burn for, that we want to see in our community and the work that we're doing. And unlike Ivan, I have to use notes to remember. So we actually came together and applied for the CHCF grant collaboratively, and talk about an interesting grant writing process. When you're applying for a grant collaboratively, it gets even more challenging. The herding cats gets really interesting. But once we had kind of determined the focus and the core values of the work, and we decided what we wanted to start with, we developed what we called our roadshow. And our physician champion, who Dr. Bill Morris, has this concept of opioid failure. And basically the concept of opioid failure is that this medication has failed the patient, not that the patient has failed the medication. And that's really important, and we hold that true throughout the work, even when we're talking to healthcare providers, leadership in the community, patients or community members, that we're really in this together, and we're going to tackle the problem together. And it's the medications that aren't working, not that the patients are bad patients. So when we take our roadshow out, and Bill and I have done it to this presentation together and separately, we really tailor. It's not a canned presentation that we give to the same over and over again. We really change the presentation each time we make it. It's really important that if I'm giving a presentation to a behavioral health action coalition, that's a different presentation than the one that I might give to Palo Alto Medical Foundation. So we give a presentation to Palo Alto Medical Foundation, and we talk about prescribing practices, and we talk about numbers of prescriptions by primary care physicians or advanced practice clinicians in their organization, and we kind of work from there. If we're talking to integrated behavioral health, for instance, we really we use the coroner's data, and we focused on the psychosocial information that the coroner was able to get to us around the patients who are overdosing in our community. So we really tailor our message to the people that we're speaking to make sure that we we have those values that are activated in us as far as compassion, equity, safety, and health, and we make that space to activate that in other people and bring them on board. And it felt a little slow moving at first, but what's really nice is now we are 9 months in, and heads are turning back again. So people who might not have been engaged at the get-go are now hearing about the work. They're hearing that these other people are involved, and they're coming back to and asking us if they can be involved in the work. And that is really heartening. It feels like it makes us feel like we're moving in the right direction, and we're gaining more community support. There was something else I was going to say about that. At any rate, this leveraging the relationships. So we have our steering committee, which is really engaged, and every time these people come together for a meeting, I'm like, wow, you're all back. This is incredible. You're all really busy, and yet you're here to do this and have lunch and talk about this and get some work done. But not only are they coming to the meetings, but they are all willing to leverage the relationships that they have in the community with their leadership, with their clinical partners that they work with policymakers. And in particular, we partnered so strongly with somebody who was already doing this type of work in our community, and that's Community Prevention Partners. And they are an initiative in Santa Cruz County that works mostly on initiatives with youth as far as substance use, marijuana, alcohol, and prescription drugs. And so when we first started working with this partner, she said to me, we've been trying to get into healthcare for ages. We've been trying to get this education to healthcare for a really long time. And I said, that's what I can help with. So we really strongly partnered with somebody in the county who has already had this background of community education. They already were collecting data around youth access to substances. They were doing some environmental interventions. And so pairing that kind of community and healthcare effort has been really powerful. And so when I'm doing kind of my 3-minute spiel about the work, that's what I say. I say, we are committed to bringing healthcare and community together around this issue. It doesn't just live in one space. So I talked a little bit about aligning efforts and our values, and I'll just say, I was thinking about the community messaging that Ivan spoke about, and how we are also committed to having some community messaging and empowering patients to take agency in their healthcare around maybe their chronic pain or their substance use disorder or whatever it is that they're seeing their provider for. So kind of calling their provider on the carpet, as Ivan mentioned, about whether or not these medications are good for their life, their quality of life, is it managing their pain. And also at the same time, our efforts have been heavily in provider education, and now we're kind of ramping up that community or patient education, trying to figure out ways, and we're just right now developing it, how to empower patients, or what kind of messages we can do to have them, for lack of a better way of putting it, challenge their doctor to make sure that this is right for their life. And so I'm going to quickly share just our lessons learned. And that the first one is that we want to be really intentional with our approach. So we want to know what's important to the particular audience, and we don't give the same presentation all the time, and don't use the same data with different audiences. Make sure that we know our audience and we know how to kind of activate that space of the shared values that we all have for our community. We leverage the relationships, as I mentioned, and we make committed requests. I'm pretty good about not just putting general asks out there. I'm pretty good about saying, well, please call me on Friday and tell me whether or not you can do this. So people, I think, I get a really good response around that, because then people walk away not thinking, well, maybe I'll call Pam and I'll talk to her about that. It's, no, really, I'm going to call Pam by Friday. I'm going to let her know if I can help with that Naloxone assessment or whatever it is. And above all, we work from the values that brought us to the effort. Again, those values that brought us to the table the very first day, and we make sure those are the underlying drivers for the work that we do.
Great, thanks so much, Pam. Are there any questions for Pam? Pam, I have one with the roadshow. I mean, there's so many different community organizations out there, so many places where you can kind of think about engagement. Have you extended the roadshow crew beyond you and the physician? And do you have any thoughts about doing that?
No, it really is just Bill and I at the moment, but we're creeping in that direction. I was speaking earlier about feeling at the point that the coalition is so strong that now it's time to start to delegate. And not just because it's a lot of work, but because that's how the work will be sustainable. So that's on the agenda, is expanding the roadshow and getting other people out there in the community to talk about it so that it can be a more sustainable effort.
Great. Questions from the audience? I have another question for you, Pam. You talked about, engaging patients and kind of challenging their physicians. Can you talk a little bit more about that? Like, how are you getting that message out to patients?
Well, we haven't gotten it out yet. Actually, last week was our meeting where we came up with potential messages. And that's now on the desk of a marketing person. That's out of my expertise, absolutely. But in that meeting, Dr. Morris talked about opioid failure, and we had that's a work group. It wasn't the steering committee. And in that meeting, we had people who hadn't been there before. We had some surgery room, some OR nurses, and we had some kind of youth. People who work with youth, people who hadn't been at the table before. It was pretty interesting. And what was most interesting about that process is the things that the group came up with as far as what we wanted to include in the messaging was not far off of anything I hear in other coalitions. And these are some people who hadn't spoken about this before. So what that brings to mind is that people really understand what the problem is. And when you give them some time to talk about it and give them a little bit of background, they're not coming up with anything really different or groundbreaking. It really is about safety and quality of life. Yeah.
Great. Okay.
So first, I just want to credit you, Kelly Piper with California Healthcare Foundation, credit you with doing the touchy-feely exercise, because I think a lot of times acknowledging why we're here, that we've lost friends, that we've lost patients, that we're personally affected, I think really helps people's commitment. But I was curious about how well is that term opioid failure resonating, and how are people responding, and is it really helping people shift away from the patient blaming or the doctor blaming that is so easy to go to in this time?
It resonates really. Did you want to answer, Vanessa? Yeah.
Oh, hold on one second.
I think it is I'm for Santa Cruz as well, and I'm on the group with Pam, and we really thank Dr. Morris for coining that term, because I think it's so important. And then that another term that came up, and we didn't create it, but it was the idea of the legacy patient, and the patient that you inherit that's already on high dose opioids and benzos. And sometimes even stimulants, and it is challenging, and how to get resources to compassionately help these patients reduce their risk, because I think when we first started meeting, there's just so much negative language about a very challenging population that I think folks were really wanting help on how to do that, because I think we've definitely, there are physician shortages in California and nationally, especially for specialists. And when you're using a lot of locums doctors, as some of our small counties are having to rely on, they inherit these patients, and the easiest thing to do is just give them the same meds. And then, the more resourceful patients, do get a bump up here and there with a new provider. So it just gets worse and worse. And, in our medical clinic, we had a physician leave suddenly, and it, quite a load of legacy patients, and how, so everyone knows very well what that means. I think it really made it a vivid, very real experience. I think we have more work to do. I still go to meetings and they're like, what can we do? But I do think it's been helpful. I think the conversation has been very compassionate.
And we have, in the creating new prescribing guidelines for our county that we're rolling out soon, fingers crossed. we've built in that term legacy patient. So we use the Oregon guidelines as kind of our model, but we're Santa Cruzing them up a bit, and including the definition of opioid failure. And the definition of opioid failure. And Vanessa, please jump in if I get this wrong. So it's our adverse effects that are unmanageable happening. Are the patients taking them as prescribed, and is their pain controlled? And so if any of the answers to those things are no, then we can move to the idea that perhaps opioids have failed this patient, and we need to find another route, whether it's tapering and complementary alternative medicines, or if it's Suboxone. And so we've built those into the prescribing guidelines, including the idea of we've got legacy patients. This isn't just about how do you treat acute pain in the ED.
So I actually have one more question for both of you, and I don't know if Ivan, if you want to start, but so many of the coalitions are saying, well, we can get doctors to prescribe naloxone, but the pharmacies never carry it, or now pharmacists can furnish naloxone on demand, but the pharmacies are refusing to do it. So I was wondering if you had advice for coalitions about how to work with their pharmacies to step up and stock it and distribute it, and I just was wondering if you wanted to comment in Santa Cruz how that's going with your local pharmacies.
So from the perspective of pharmacies providing naloxone, pharmacists are now permitted to essentially dispense naloxone without a prescription. The regulatory environment has changed recently, and pharmacists are permitted to do so. There are some logistical challenges that some pharmacists have reported, one of them being price. And the context of allowing the pharmacist to dispense it without having a prescriber prescribing it is great. But then the patient comes to the pharmacy and asks, may I please have some naloxone? Pharmacist says, yes, of course you may. Please give me $100. And that's where it becomes a problem. In many instances, the patient may be on Medicaid or maybe of relatively low income. And even though the naloxone is a safety net that it's great to have, that patient may have to make a decision. Do I use that $100 to fuel my drug habit, or do you use that $100 to purchase a safety net? Again, the answer frequently is A. The safety net does not become as important for them. So price is definitely a barrier. Our organization was able to procure some donated naloxone in form of the FZO injectors through Kaleo Pharma, and we distributed it to several local clinics and healthcare providers, and those have been given out to the patients. We're also working on providing naloxone through the grant to local first responders. The plan is to have all Shasta County sheriff's officers and squad cars equipped with naloxone. Interestingly, we've run into a little bit of a challenge with some administrative issues, but we're working through it. It's not a big deal. So from the pharmacist standpoint, a lot of pharmacists would be willing to do that, but again, pharmacies are in place to provide livelihood for those people who run them, so we cannot expect them to give it out for free. Somebody needs to pay for it. The second part is when the physician actually prescribes that. Some pharmacies have reported that the reimbursement rates provided through either private insurances or state-run insurances were below their acquisition cost. And I don't know whether that's actually true or not. This is just an anecdotal report that I've received from some pharmacists. I just spoke to a gentleman about it earlier on, and he said that pharmacists in their county are able to produce that without any adverse effect. So this may not be accurate, but it was brought up that the cost both from the private pay and the third-party payers may be an issue.
Pam, I just wanted to add to the question that Kelly asked you. There is a question from somebody out in Santa Rosa, Sheila from Santa Rosa, and she asked, have you made or plan to make any presentations to UCSC or community colleges in Santa Cruz?
That's a great question. We have people from UCSC involved in the coalition work, but we've not yet done a presentation there. It's and we haven't talked about what that might look like, but it's, again, we're a pretty young coalition, and we're feeling our way around this a little bit, and we want to include as many community partners. The university is it's a big deal to have the university there, and in general, there is a bit of a division, kind of the university and community interaction. It's very much, UCSC is its own little world up there, and we're not always great about bringing our kind of local community and the student community together, but we want to work on that. Yeah. As far as the naloxone question, we have a lot of work to do when it comes to naloxone, and it's really clear to us. We did a small kind of assessment of who had any kind of naloxone distribution programs, and we found that several people did have it to distribute to their clients, and they were trained, but everyone was getting it from one source, which was the Substance Use Disorder Treatment Program, Janus, Santa Cruz. And so they kind of have been the hub of training and distribution, and so we want to step up community distribution programs, but at the same time, we're having similar problems with, I'm hearing providers say to me all the time, yeah, well, I write for it, and it gets, the pharmacy says that it's not covered by our Medi-Cal managed care program. And so we know it's fee for service, and we have to bill state Medi-Cal, and so we have some education to do in the pharmacies, some academic detailing perhaps to do in the pharmacies, but also we want it to be in other programs like our needle exchange program. We're hoping to get the naloxone distribution through that, possibly, and I know that our new public health officer has been meeting with law enforcement to get them trained and start carrying naloxone as well.
All right. Well, we are just about out of time. Is there are any other quick questions? Last questions for Pam and Ivan? No. All right. Well, I want to give. Let's all give them another round of applause.